Hey, I'm Jocelyn Compton. Welcome to the Musculoskeletal and Connective Tissue Lectures. Chapter is going to cover a wide range of topics pretty quickly. While there are some high-yield topics covered here, many are fact-based and don't require as much conceptual understanding as they do repetition. I'm going to attempt to provide as many memory aids as I can and pictures to make this easier, and also indicate specifically which facts are likely to be higher yield than others. The trick here is to be strategic about the facts, and not to drown in too much musculoskeletal minutia. Let's kick things off with anatomy and physiology. To begin, we have the skin. It's the largest organ in the human body. Do you remember the 5 layers? On the top, there's the stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum, and the stratum basalis. You can remember this fact with the mnemonic, Californians like girls in string bikinis. Also note that the stratum lucidum is only present in the thick skin of the palms and the soles. So how are you going to remember this? Remember that L in lucidum is the only letter that is also in both words palm and sole. This diagram also covers a fairly important set of topics. The structures we're going to discuss provide the integrity of the epithelium and allow cells to have specific functions. Here's the apical side of the cells up here, and the basolateral side is down here. The first structures that we're going to discuss are the different junctions that are key to forming the body's outermost layer. These are the tight junctions, or zona occludens, and they're found apically along rows of epithelial cells. They prevent diffusion across the paracellular space, which is right between the cells. And they prevent large molecules and even individual ions from diffusion. They're made up of 2 molecules, claudins and occludens. And ultimately, they form a zipper around the cells. Just remember that the tight junctions bind so tightly that they don't allow most substances to pass through. The next structure is the adherence junction, or the intermediate junction. This surrounds the perimeter just below the tight junctions. The functional proteins that form these intermediate junctions are cadherins. Cadherins attach to the intracellular actin molecules, which normally function in the cell's own cytological skeleton. What is an important ion to cadherin function? They rely on calcium, and actually it's where they get their name from. The phrase is calcium-dependent adhering protein. So if you can't remember what ion is important in their function, just remember, it's all in the name. Next, we have the macula adherens, which are also more commonly known as desmosomes or spot junctions. How are these connections different? They are literally small, discrete sites of attachment, a lot like a drop of glue. They utilize the same proteins, cadherins, but rather than attaching to intracellular actin like intermediate junctions, they attach to intracellular intermediate filaments. And yes, this is kind of confusing and even a little bit backwards. But why do we care about desmosomes? Because they are key to the pathology in pemphigus vulgaris, which we'll do a bit more in-depth review in the derm section. Just briefly though, patients have autoantibodies to these spot junctions, most often visible at the level of the skin. So, if you think about it, if all the epithelial cells lose their spot junctions, they would lose their ability to hold on to one another. And then what's going to happen? Separation. This happens in enough areas throughout your body. It would form these huge blisters, which is the characteristic presentation of pemphigus vulgaris. A very similar structure to the desmosome is the hemidesmosome, which you see right down here at the basolateral surface. It's sometimes called a hemidesmosome because it literally functions like just a half of a desmosome. It does not connect 2 cells to one another, but rather one cell to the basement membrane at the basal portion of the epithelial cell. Similar to pemphigus vulgaris, patients that develop autoantibodies to these hemidesmosomes will also develop a blistering skin disease, but is named bullous pemphigoid, which is probably the setting where you're most likely to see these structures appear on the test. For step 1, you'll need to pair these in your mind. Pemphigus vulgaris and desmosomes, and bullous pemphigoid with hemidesmosomes. Additional structures that are used to maintain the integrity of the basement membrane are integrins. They function by binding to laminin in the basement membrane. A final structure on epithelial cells is the gap junction. These junctions allow adjacent cells to communicate for electrical and metabolic functions. This provides an efficient and effective way for one cell to communicate to another cell, as you can see right here. Gap junctions are found in many organ systems. For example, some muscle cells, specifically cardiac muscle cells, will spread electrical signals using gap junctions. So some neurons can synapse at a single site and still have that message passed down to many, many cells beyond it through these gap junctions. It saves a neuron from having to pass the message individually to every single cell. It also enables coordinated contraction of the heart from the bottom to the top so that the blood is pumped out, with the signaling originating all in the SA node, as outlined in the cardiovascular chapter. Pretty efficient, right? Okay, let's have a flash quiz. What layer of skin is found only in the palms and the soles? The stratum lucidum. Want a little flash quiz bonus? Which is the stratus lucidum layer in this picture? It's right here in the pink. Next, we'll make a brief foray into orthopedics. While you may not see a lot of questions around this topic, there are a small spectrum of bone diseases, mostly traumatic and metabolic, that you do need to be aware of. I think this section frustrates a lot of students at first because human anatomy in its totality is extraordinarily detailed, and there are, in theory, an almost infinite number of ways that a person can sustain injuries. That being said, however, the way this subject is tested on step 1, there are really only a handful of common, typical injuries that you need to understand, meaning that this is a subject that can be memorized just like any other. So don't worry, you can totally do this. First, let's review some basic anatomy. This is the knee joint. You notice this knee has a medial collateral ligament tear, right here. If I told you that this knee was a football player's, could you imagine how that might have happened? If this is what you're thinking, you're totally right. Okay, back to the ligaments. First, we have your 4 ligaments, the LCL and the MCL, which you find at the periphery of the joint, and the ACL and the PCL, which you find at the center of the joint. These denominations, A, M, P, and L, all refer to sites of tibial attachment, and not the femoral attachment. So what's the unhappy triad? Imagine your favorite football player is running for the end zone. To stop him, a defending player may dive straight through his legs, often from one side. The resulting hit is to the lateral portion of the knee and would cause 3 injuries. The first 2 are ligamentous, to the MCL and the ACL. See how these components sustain stress from a lateral hit? The third is meniscal, to the lateral meniscus. I keep this all straight by remembering that an unhappy triad injury makes you lame. L is for lateral meniscus, A is for ACL, and M is for MCL. A lateral knee injury in a contact sport is probably the most common way that this will be presented in question stems. In certain clinical vignettes about orthopedic traumas, your only clues to certain injuries may be abnormal physical exam signs. There are 2 commonly discussed physical exam signs that you will be expected to know for your boards. The first are the drawer signs, and the second is abnormal passive abduction. The anterior drawer sign indicates a torn ACL. This occurs as the tibia is now able to freely move anteriorly, along a fixed femur. Remember that the A or the P in ACL or PCL is the same direction in which the tibia can freely move once it's injured. As in, if you have an ACL injury, you will notice that on physical exam, the tibia can be translated anteriorly or toward you, the examiner, farther than normal. The next sign is abnormal passive abduction. If you think about it mechanically, abduction at the knee joint is minimized by a strong ligamentous attachment between the tibia and the femur through the MCL. If the MCL is torn through, these 2 bones could be passively abducted abnormally, leading to a higher clinical suspicion for an MCL injury. In this case, the M or the L in MCL and LCL is the opposite of the direction the tibia can move freely when it's injured, pivoting away from the body abnormally. So if you have an MCL injury, you should be able to shift the tibia into which direction? That's right, you'll be able to move the tibia laterally, away from the body, more than usual. Let's have a flash quiz. If this ligament shown here were torn, what might you expect to find on physical exam? An anterior drawer sign, because that was the ACL. This section highlights certain facts that are important for your ward's experience and may be seen on a handful of Step 1 questions. As you become experienced clinicians, you'll learn that much of the art of medicine is being able to access human anatomy using certain landmarks. For example, the boards could present you with a patient who's in labor and needs pain management. What nerve can you access quickly transvaginally? Yeah, it's the pudendal nerve. This is done by inserting a needle transvaginally and pointing it directly towards the ischial spine, which can be palpated, and injecting it presumptively at the pudendal nerve, which cannot be palpated. Remember, the ischial spine is a landmark for pudendal nerve block. It's important and it comes up a lot on tests. Accordingly, when a febrile patient complains of right lower quadrant pain, it's often prudent to see if it occurs in the region of McBurney's point, since pain here would alert you to appendicitis. This is a location 2/3 of the way from the umbilicus to the anterior superior iliac spine is the site of the appendix, as you'll recall from the GI chapter. A final landmark to be aware of is where to do a lumbar puncture. What is an important structure that is located at the level of L1 or L2? The conus medullaris, which is part of the spinal cord. The needle should be below the conus medullaris, around the cauda equina, in order to avoid spinal cord injury. Why is it better to puncture here rather than higher up? Imagine sticking a fork into a bowl of spaghetti. You're unlikely to puncture a single spaghetti, much like doing a lumbar puncture at the level of the cauda equina. Okay, to perform an LP, you find a place midway between the iliac crests, and this often corresponds to the L4-L5 space, which is another fact that often appears on tests due to its high clinical utility. Let's do a flash quiz. Autoantibodies to what epithelial attachment results in pemphigus vulgaris? Desmosomes. Hemidesmosomes are bullous pemphigoid.